Now to speak to you about surgery, let me pass you over to Dr. Wassef.
Hi, my name is Dr. Ramses Wassef, and I'm a surgeon at the Hôpital Saint-Luc, which is part of the Centre Hospitalier de l'Université de Montréal. I've been asked to explain the most invasive form of treatment for Crohn's, surgery. Now, you may never have to have surgery for your Crohn's, but knowing more about it is still a good idea. Surgery is not the first line of treatment in Crohn's, and your doctor will try to avoid the need for surgery by encouraging strict adherence to medication. But don't look at surgery as a desperate measure, because we often use it to help relieve severe disease symptoms and to help lead to remission. The goal of surgery in Crohn's is to help you return to a better quality of life while leaving healthy sections of gut where we can. But let's be more specific. There are generally two situations that lead to surgery. One occurs when drugs are not working. We refer to that as medically refractory disease. The second occurs when complications develop, like a fistula, an abscess, scarring or narrowing of the intestine, or if the drugs we are using to help manage the disease are causing severe side effects and cannot be stopped because the symptoms recur right away. Generally, we do something called a resection. That's a medical word for removing the diseased part of the intestine and any related abscess or fistula. We then do something called an anastomosis, which is a big word for reconnecting the two ends of a healthy intestine. The good news is that this type of surgery can lead to years of remission. However, it's not a cure, since Crohn's can return. Now, when there is no healthy intestine to connect to after a resection, we do another form of surgery. Like when a patient has inflammation in both the colon and the rectum. In a situation like this, after the rectum is removed, something called an ostomy will be done, where we bring the section of the bowel up to and through the skin. This allows for waste products to leave the body through the abdominal wall and into a specially designed pouch attached to the opening. Depending on what part of the bowel is brought to the surface, the procedure is called an ileostomy or a colostomy. What happens then is the patient fits an appliance, we call it an ostomy bag, on the skin around the ostomy. It usually comes in two parts. One is something like a wafer or a base plate that will actually stick to your skin. We cut out a hole in the middle, just the size of the bowel that's sticking out. The other part is the bag itself, which snaps onto the base plate, a bit like a Tupperware seal. The bag has a clip at the bottom, so it can be removed and rinsed before being re-snapped onto the base plate. Every few days, between 5 and 8 usually, the base plate itself has to be changed because it's not sticking to the skin as well. I know it sounds quite drastic, but the reduction in symptoms would make learning to live with an ostomy worth it. Of course, for any patient, hearing that he or she needs this kind of operation is a major step and a major change. But there is now a lot of support that a patient receives, and it can really be very helpful. Usually the patient will be followed by a specialized nurse called a stomotherapist, who is very knowledgeable in the care of patients with ostomies. There are also support groups created by patients. It's absolutely normal to be scared of such a change, and you should feel free to express your feelings and ask all the questions you may have when you are advised that you will need an ostomy. Other common surgeries in Crohn's include closing fistulas, removing scar tissue, and something called a stricturoplasty, which involves widening a section of your intestine that has become too narrow from swelling or from scar tissue to work properly. If surgery has been suggested by your physician, it's a good idea to prepare a few questions before you meet your surgeon. It also may be a good idea to go with a family member or a friend, since you may be a bit nervous and forget questions or answers you hope to discuss. Some of the important questions I would suggest you ask your surgeon include: Number 1, how sure are we of the diagnosis? Could it be something else than Crohn's? Number 2, do you think surgery is the right treatment at this time, or should some other treatment be tried first? Number 3, is there any contraindication to surgery that you see? Any reason not to operate? Number 4, what are my options in terms of operations? And finally, number 5, what are the risks and possible consequences of these options? I know one of the difficult concepts when considering an operation for Crohn's disease is that one may go through all of this and still not be cured. So let me talk a little bit about that. In many diseases, we know that if we remove the part of an organ that has the disease, or even the entire organ, then the patient is cured and the disease will never come back. One easy example would be appendicitis. Once we remove the inflamed appendix, then that's it. The disease cannot come back and the patient is cured of this problem forever. That is not the case with Crohn's disease, because it's a disease that can affect any part of the bowel, and in fact also the stomach, the esophagus, even the mouth or the anus. And since we can't remove what we call the entire gastrointestinal tract, we have to live with the fact that although every visible diseased part may have been removed, the disease may still come back. It can do so either very close to where it was initially or at any other location along the gastrointestinal tract. Now, I'm not saying it will come back, just that it might, and it's very unpredictable. Relapses can happen in some cases within a few months, in others in a few years, and in some patients the disease may not show up again or be in remission for a long time. But once again, surgery will at least relieve severe disease symptoms and help lead to remission. Once you have healed from the operation, your physician will discuss with you the idea of medication to try to prevent or at least delay the recurrence of the disease.
Thank you, Dr. Wassef. Well, we got through the really tough stuff. Now, hopefully, you can join in the conversation for your ongoing care with your healthcare team and make more informed decisions. Remember, the better you understand your disease and treatment options, the better you'll be at taking care of yourself and at helping those around you do the same. Now, would you like to find out more about lifestyle? Or, if learning how to deal with stress is important to you, you may want to check that out.